We don't have we don't have positioning in the morning, well, because we have the back-to-back classes. We keep you guys together as a group. So we have our evening class, which is special procedures for venipuncture. We schedule that in the evening because we try to coordinate with the facility, some other facilities for you guys to participate in different types of field trips, and they're only available in the evening. So if I did you guys here in the morning and then special procedures in the afternoon, then we have this big break in between. So we try to do it back to back. What you're also going to see is that what I like to do is I try not to have a huge break in between. So whenever I'm done here with the positioning part of it, I go straight into 162. So that way, if we finish early and you guys can go home. So the schedule says we're here until what, 8:45 or 9 o'clock? No. They're just excited to be here.
I am excited to have them here. This is great. Good to see everybody all together. And you're all here, right? You're all here?
Yeah.
Okay, good. I'm sorry to interrupt. Just real quick. Julie Holland.
Put it in a note? Or...
Yeah.
Oh, sweet. Thank you. Thank you.
So I think she's got everybody.
There's two. I just opened the
Thank you, Robin. I was clapping so loud the whole thing, and it hurts now. It's so funny how these kids came in this small. It's like it looked like all this was for her. Also,
Perfect timing.
perfect timing. She just.
First time in the room.
There's two.
Cool. Thank you so much.
And thank you.
I'm your camera woman. Can I see your ring? I like it. Tungsten? I thought you said tungsten.
So it's non-scratch.
I like it. And I like it how it's all smooth. Just it looks very stylish. I like it. Was well with your watch.
I just heard it. I'm like,
Cat. Okay. I'm calling you Cat now. You know how we're saying people who get confused? I'm thinking with my same Kate and Cat. And then when I say, oh my God, we're going to be getting confused. So what happened now? I'm calling her Cat. No, see, I'm mixing us. Oh my God.
special. I just observed a hip injection for pain management. So they're doing arthrogram, fluoroscopic procedure. The doctor is doing it. He's very friendly.
Oh my god, I had to be a witness for nuclear med, and the radiologist came in, he denied and acknowledged me the whole time.
Same here.
No, the med doctor, he was nice, you know. But the radiologist was like, I was like a little peasant, and here he comes, oh my god.
I never, no title in the world, no financial situation, not ever. In my life. Some people might but no.
Okay, so what I was saying, guys, is I like to try to get the class back to back with minimum breaks in between. So After we finish class, I'll ask you guys want a 1 hour break, you want a 1.5 hour break, and you guys, give me a consensus of how long you guys want to come, have your break, and then we start up on 162. But here's the catch is, we also got to coordinate it with Mr. Benoya because he does work full-time, and I usually tell him for 162 to get here about 3:30, 4 o'clock. And so that's 2 hours ahead of what you're scheduled for. And then again, we don't go historically past 6:30.
Oh my God. That's so much.
Okay, so there'll be some times when we have to stay a little bit later, but for the most part, we leave around that time.
So wait, Benoya reads this class or Finesse? Who 162? Oh, they both?
No, that's what I'm
or
saying.
half of the class,
Yeah,
one
that's what
lecture,
I'm saying.
another?
I go back to back, but I give you guys an opportunity to go get something to eat, whatever.
Like at the same day, both of them do. Not like 1 week one, next week another. How?
That I don't know. I don't know what time they're open till. Yeah.
So Dr. Raf, you and Benoya both teach lecture the class? 162.
I'm going to be lecturing the class.
Oh, okay.
He's going to be the lab portion of it when we do the venipuncture.
Ah, okay.
Yeah. There may be a class or two where he is going to lecture,
Oh,
but
okay.
for the most part, I'm going to be the one lecturing, and then he'll come in when we do the venipuncture.
Okay.
Yeah. 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 You're also going to submit your papers soon. We have 2 papers in 162 that I'll talk about later. They're not really papers. It's more of a project for you guys to get familiar with your institution. Okay. And it's we say it's a paper, but it's in paper form, but it's more again to get to know how your department runs. Okay, and then you're going to be submitting your assignment to Mr. Benoya for him to grade. Okay. All right. Let me just set up here. Yeah, Miss Smith just told me our original director from the program just passed away. Yeah. He was I think in his 80s. Yeah. And he left Cyprus here back in 87, 88. That's a long time, yeah.
I got goosebumps because
So I think he was the original director here. Did you guys know the X-ray program started out in Fullerton College?
What?
Yeah, it started out from Fullerton College.
Ah, from there.
Yeah.
Okay.
And then it moved over here, and then that's the director I'm talking about. I was just telling Kat, the original director here at Cypress College just passed away. He was in his 80s, and he retired here in 87 or 88. Then Bob Corelli, if you guys know Bob Corelli, he became director. Then he passed away.
Oh no.
And then that's when Miss Mitz became director.
She's alive.
So we've had 3 directors.
That's called life. That's sad.
But that's kind of how it happened. So when he passed, when his name is Clay Ward, he was director. Pirelli was down here. So when he passed away, Pirelli moved up. Then Ms. Smith was hired, and then when he passed away, then Ms. Smith took his position.
No.
I only met the guy a couple of times too. When I met him, he was
Or like some of the people in this class were not even born when he.
exactly.
Yeah. Wow. Daniel, you know, like the picture you sent with you and your wife, she looks to me like Miss Peck. She does remind me, at least on the photograph, like on the picture, I look at her, I'd never seen her in real life, right? But in the photograph, like, I was like, oh my god, it's like, first when you said when you were drinking Hennessy or something like that, I was like, literally, I look and then wait.
No
I was like,
way.
oh, this is spectrum.
No.
Oh.
Why don't we take it? Oh, no, no. Not there, up here.
Dude, but you still carry, the legacy carries on no matter where you It doesn't matter. We're gonna be like, oh, someone needs to position well with Robinson's in the bottom. Okay, we're gonna wait. And look, there's a fan here, so you can. Oh, you cut your hair.
Yeah, you can cut it in summer.
Oh, okay. Yeah. Summer.
Yeah, I cut it.
Oh no, it's okay. Dr. Raff is waiting for it. Dr. Raff is waiting.
100 plus lights. So,
Awesome. Social part. Yeah. I mean, no, that I do. Social part.
All right, guys, so we're going to break up the digestive system into two different sections. Some of the material that we'll be covering in the first part of this, you should be already familiar with when we were talking about the abdomen. So again, there may be some redundancy here, but I'm just going to try to fly through it as quickly as I can without you guys losing any type of information. So again, we'll break it up into two different chapters. We'll do the upper gastrointestinal tract, and then we'll do the lower gastrointestinal tract next week. So the alimentary canal, your food pipe from beginning to end, begins at the oral cavity through the through the pharynx, down the food pipe, which is the esophagus, then the stomach, then the series of small bowels. So you have the duodenum, you have the jejunum, and then the ileum, and then you have the large intestines. And we'll talk about that next week. We have the accessory organs. Let's see if it breaks down here. The accessory organs, you have the salivary glands, and that's where digestion begins through mechanical means, that's a chewing, and then also the saliva that breaks down the products chemically. So the salivary glands, along with with chewing, mastication, is also going to aid in digestion. And the salivary glands includes the parotid, the submaxillary, and the sublingual. We'll talk about that there in just a little bit. Now, pancreas, an accessory organ. What does it produce? Insulin. Okay, so what does that regulate? Sugar. Okay, your sugar levels. Okay. Then we have the liver. What does that produce?
Bile.
Bile. And what does that?
Emulsified fats.
Emulsifies fat. Okay. And then bile is stored in the gallbladder. So the salivary glands, the saliva is composed 95.5% water and 0.5% solid salts and digestive enzymes. So we have the three glands. We have the parotid, submaxillary or submandibular, and the other one is the sublingual. So here is the parotid. Parotid means near the ear. Near the ear, so that's your parotid gland. Then you have your submaxillary or submandibular. There's two names for that. And then the third one here is sublingual, below the tongue. Okay, so again, digestion begins at the mouth, the breaking down of the food. But let me know if I'm going too fast.
What was the third one, sublingual?
Sublingual. So we have parotid, submandibular or submaxillary, and then sublingual. It should be, yeah, it's on your previous slide. Okay, yes, right there, yeah. Okay, so before we begin talking about the rest of the alimentary canal, we're going to talk a little bit about the liver and gallbladder. We do have procedures that still involves mostly the gallbladder. You will see these type of procedures happening mostly in the operating room when they do, remove the gallbladder. We take images of that in the OR. So, as you guys should know by now, the liver is in the right upper quadrant, and the gallbladder is going to lie right behind the liver. The liver is going to be broken down into 4 different lobes. We have 2 major lobes and 2 minor lobes. The major lobes are best demonstrated anteriorly. You have the right lobe and you have the left lobe separated by the falciform ligament. Okay, so again, the major lobes are seen anteriorly, separated by the falciform ligament. The minor lobes, you see it on the back side, posteriorly, in between the right and left lobes. So beginning with the quadrate lobe, which is lower or inferior, the quadrate lobe is separated by the gallbladder and the falciform ligament. And then above that is going to be the caudate lobe. Now, the gallbladder, which is situated behind the liver, it stores bile. So, we have these vessels, we have these ducts that also communicate with the liver. You have your right hepatic duct and you have your left hepatic duct. Okay. So bile is produced by the liver, and it's delivered through the right and the left hepatic duct. The right and the left hepatic duct are going to join to form the common hepatic duct. And from there, the bile can either keep on going to the common bile, or can be redirected to the cystic duct to be used later on. From the common bile duct, it's going to join up with the pancreatic duct, and then bile is delivered to the most proximal portion of the small bowel, that's known as the duodenum. Did we have this conversation before? Duodenum, duodenum? Yes. Okay. All right, so bile then is delivered to the duodenum. Duodenum. Now, let me just look at the other slide here real quick. I want to make sure that I give you guys all the information for this particular slide. Okay, so the area where the common bile and the pancreatic duct meet, this is going to be called the, it's on the other slide, over here. It's going to be called the hepatopancreatic ampulla, or the ampulla of Vater. Okay, this is where the common bile duct and the pancreatic duct meet. This area here is known as the ampulla of Vater. Now, it says here that it's found in 60% of the population. What that means is the other 40%, you have 2 separate ducts. You'll have the common bile duct, and then you'll have its own pancreatic duct emptying or communicating with the duodenum. But 60% of the population, it converges. Okay, and it converges at the ampulla of Vater. Now, you'll also see here, you see this where it says duct of Wersham? That's just a special name that they gave for the pancreatic duct at its distal end. It's still a pancreatic duct, but this particular area here is known as the duct of Wersham. It's just a fancy name. Wersham, Wersham, Wersham. Now, the ampulla of Vater will then become more narrow, forming just, again, one duct. And this is known as the pancreatic sphincter. So there's another duct, and then it closes up or gets more narrow at the sphincter of Oddi is the other name for it. Now, that's going to be the most common place for stones to get caught. So it's a common place for blockages by stones. Any questions so far? Now I'm going to back up again. So let's talk about now the gallbladder, the parts of the gallbladder. Very simple. The gallbladder is broken up into 3 different parts. You have the neck. This is the area right here. It's pointing to this, but it's actually this area right here. This is the neck. The small part of the gallbladder. This is the neck. Then you have the body. And the distal part of the gallbladder is known as the fundus. The gallbladder is 7 to 10 centimeters in diameter and can store up to 30 to 40 milliliters of bile. Now, how does the gallbladder activate? It is activated when your body senses fat. Okay, so when there is fat that your bowels senses, the gallbladder is going to release what's known as CCK or cholecystokinin. Okay, so when there is presence of fat, CCK is released. CCK is released. What the cholecystokinin is going to do in the presence of fat is that it's going to increase the amount of blood supply to the gallbladder, causing it to contract. CCK is going to increase the amount of blood supply to the gallbladder, causing it to contract. And at the same time, that CCK is going to cause the cystic duct, it's a spiral duct, it's going to cause the cystic duct to relax. So the gallbladder contracts, the duct relaxes, allowing the bile to flow down the common bile duct. Now within the gallbladder, again, we have the bile. There's an even amount of concentration of bile versus water in the gallbladder. But sometimes what can happen is that the water in the gallbladder is excessively removed through the process of hydrolysis. Hydrolysis, again, is just kind of putting water in, taking water out to try to keep the concentration of the bile even. So again, if it removes too much water, the bile now becomes very concentrated, and that's how you end up with stones, choleliths. Okay, so if we're talking about medical terminology. If we break this down, chol is referring to the gallbladder, and liths is stones. All right, any questions about how the gallbladder contracts and delivers bile? Okay. The anatomical relationship of the gallbladder. This is a lateral diagram of the abdomen, and you can see here is your front, here is your back. The gallbladder is anterior. So if when we're doing a procedure, again, it's not as common anymore in radiology, so we do most of our gallbladder studies. Where are gallbladder studies done, by the way? Where are they done mostly?
Ultrasound.
In ultrasound now, okay? But again, we still do some limited studies of the gallbladder, and they're usually found in the OR. Now, for some reason or another, if the gallbladder cannot be demonstrated by ultrasound, yes, they will come to our department where we will fill that bladder up with contrast to do some imaging studies of it. So the gallbladder is anterior. So if you wanted to take a picture of the gallbladder filled with contrast, are we going to do it AP or PA? Why PA?
Closer to image
Closer to the
receptor.
image receptor to minimize any type of magnification, get you better detail. Now, if you also look at the anatomy of it, the ducts are posterior. So if you wanted to observe the emptying of the gallbladder, now we would put them in an AP position. We would do it. We would flip them on their back to watch the gallbladder drain or empty. Does that make sense, guys? So PA to minimize OID, but if we wanted to observe the emptying of the bladder, we would do it supine or AP. Now up here, I put up here RPO. In the operating room, when the patient is having a cholecystectomy, they're having their gallbladder removed, what the doctor is going to want to do is he's going to inject contrast into the ducts to visualize patency and to make sure that they didn't damage the ducts in the process of removing the gallbladder. Doctors remove the gallbladder for various reasons. One of them is because the patient just has so many stones, so many blockages that they can't just take those stones out. They got to remove the entire gallbladder out. So in removing this, okay, removing the gallbladder and clipping the vessels, they want to make sure that they didn't damage the surrounding vessels. And so they're going to call you in to do an x-ray. The doctor's going to inject contrast into the ducts. You snap a picture. But before you do that, the patient, first of all, is going to be laying on a table that just doesn't go up and down, but you can change the angle from RPO to LPO. Okay, and we can also tilt, Trendelenburg and reverse Trendelenburg. But generally what the doctor would like to do is they'll tip the table to the right, okay, with your cassette underneath and your x-ray tube on your top, the portable x-ray unit. And they're going to place the patient in an RPO position. The purpose of the RPO position places the gallbladder away from the spine for better visualization, because in an aesthetic type of patient, average size patient, the gallbladder is going to be near the center. Okay? And when you do an RPO, they're laying on their side, where's the gallbladder going to go? It's going to roll off away from the spine. So when you shoot an x-ray of the gallbladder in the operating room, the doctors are already going to place that patient in an RPO position to best visualize the gallbladder away from the spine. Okay, any questions about that? You will get called often, probably not as students, when you're following your tech around. They get called in often to do gallbladder studies in the OR. And so we were talking about body habitus. So stenic, hypostenic, again, the gallbladder is somewhere near the middle. So when you put an RPO, it moves off to the side. So is it good to know where the gallbladder is based on body habitus? Yeah. You go to the OR, the patient's draped. Okay. Are you allowed to touch the body landmarks of the patient? No. So you gotta be able to use your head, your brain, on an average sized patient, so I'm going to give you guys a little clue now of where the gallbladder is located without having to touch the patient. The gallbladder is generally at the level of the elbow. That's it. Okay? So when you're placing that image receptor underneath the surgical drape, underneath the table, you're just moving the image receptor at the level of the elbow. If they're hyperstenic, higher than the elbow. If they are astenic, lower than the elbow. Again, when you shoot these x-rays, you can't touch the patient. The patient is sterile. And if you contaminate the surgical site, the doctor's going to tell you to get the heck out. So you can do it without having to touch the patient. Well, how do you find the elbow if the patient's draped? You guys remember 153? Anything below the surgical table is not what? It's not sterile. You guys remember 153? Patient care? So anything below the surgical drape, anything below the table, the surgical drape is not considered sterile. So you just lift up the drape, go underneath. Now you can see where the elbow is. And place your image receptor at the level of the elbow. But when you lift up that drape, you guys remember anything above the table is considered sterile. So you want to make sure that when you lift up the drape, you're not what?
Lifting above
Lifting
table.
it above the table. So as you're going down there, pointing your image receptor underneath there, can you rub against the doctor's legs? Sure you can. It's not sterile, right? Yeah. So if you touch anything below the level of the table, it's okay. It's everything that's above that's a no-fly zone. Okay? So we'll talk about cholecystectomies again throughout the course. So here is a cholangiogram that was done in the operating room. Contrast can be introduced to the gallbladder in several ways. Again, one is through just direct injection into the vessel to light up the gallbladder. We can also give the patient what's known as barium pills. So the barium comes in the form of a pill. They pop it in their mouth, and eventually that barium finds its way into the gallbladder, and it's highlighted just like so. All right. So this is a gallbladder that was done. Looks like it was done not in surgery, but done in department. And this is an RPO. How do I know it's an RPO? You guys are going to learn about this later on. Who just said it? Remember the Scotty dogs? Did we talk about the Scotty dogs?
Yeah.
Okay. The Scotty dogs are found in the lumbar spine. They're found in the lumbar spine. And it's formed by the pedicles, by the transverse process, the inferior and superior articulating surfaces. I know this all sounds like blah, blah, blah right now, but here is the dog. There's the nose, there's the ear, there's the eye, there's a foot, there's the other foot, and there's the tail. You guys see that?
It's like a shark.
Yeah. Okay, shark's fine.
No, you're drawing. Just you're drawing.
But you see, there's one there, there's another Scotty dog there, okay? So, the nose of the dog, this is the nose, points to the direction of obliquity. So the nose is pointing towards the right side. It's an RPO. Okay? Cool, right? So I just gave you guys a lumbar lesson. We're not even going to be talking about lumbar for another few weeks, but you just got a lumbar lesson. Okay? But you guys see another one right here, nose, ears, feet. Shark.
First.
Okay. So that's an RPO. All right, let's do some anatomy. Gallbladder, distal part. What's the most distal part called? Fundus, body, neck, cystic ducts. It's a spiral cystic duct. Okay, the spiracle. All right. You guys don't have this on your slides. So I think all you guys have are just these two images, right? It basically just, it's just a summary of the type of procedures that are done in the OR. The type of procedures that we'll be doing in the OR. The first one here is an operative cholangiogram. Again, we're called into surgery because the doctor, for some reason or another, is going to remove the gallbladder. It's an operative cholangiogram. So why are we doing these procedures? Well, to detect stones or stone fragments and other abnormalities in the bile duct, such as a stricture or narrowing, abnormal growth, or also abnormal openings. This is why we do this procedure to begin with. So an operative cholangiogram, col is what? Gallbladder. Angio is referring to the vessel or the duct. So we're going to take a study of the ducts of the gallbladder. Operative cholangiogram involves injecting the contrast dye directly into the common bile duct during open surgery. Images are then used to guide the surgeon and to identify any stones or other obstructions for immediate removal. So, best case scenario, they find stones. Okay? They extract the stones, will do a cholangiogram to see if the vessels are wide open and there is no occlusion. Worst case scenario, there are so many stones they can't remove it, so instead of removing the stones, they're going to get rid of the gallbladder. You guys follow so far? So when they remove the gallbladder, again, we're going to take a picture of the ducts to make sure that it's patent and not damaged. So here is a cholangiogram after the removal of the gallbladder, because the gallbladder should be right here. It's gone. So all we're seeing is part of the cystic duct. Okay, so we'll inject the bile duct to see if it's nice and open and there's no contrast leaking in the surrounding tissue. Now, some doctors, what they'll do after the patient has had a cholecystectomy, after they have their gallbladder removed, the doctor will purposely leave a tube inside the patient's bile duct. Okay, it's hard to see, but there is a tube here, and this is part of the tube, the catheter, that extends into that vessel, and this tube is sticking out of their abdomen. This is known as a T-tube. A T-tube catheter. It's a rubber catheter that extends from the outside of the patient and into the bile duct of the patient. And then, if you look over there to the right, a T-tube cholangiography is typically performed 5 to 10 days after gallbladder removal. Contrast is then injected into the T-tube for evaluation. And again, if the vessels, the ducts are nice and clear, how are we going to get rid of that tube? Do we have to go back in and remove it? It's rubber. We just pop it right out. And then you put your finger in the hole, and then put a Band-Aid on it, and they're done. They go home.
You go with them.
I don't go with them.
Hold.
Okay. So what you're